coming from US, and I would like to ask our second guest speaker, Dr. Sulejman Çelaj, for his presentation. Dr. Mani, the floor is yours.
Quoting a song that usually my kids listen in a car when we're going on trips, and it says, "What doesn't kill you makes you stronger." And I adopted to what didn't kill us made us stronger. During the sad and tragic global pandemics that we had, we learned a lot, right? We learned to value freedom, which is so important, value health, value life. In our medical profession, we also learned how to adapt in order to take care of our patients. We, in our hospital and around the state, the New York State, we postponed many office visits during the pandemic crisis in order to protect patients from possibly contracting COVID, while at the same time maintaining the care of people who continues to have urgent needs regardless of COVID. So we were postponing and canceling all elective procedures. At the same time, we were putting ourselves in danger of getting sick and potential fatal consequences. We know that we lost around the globe many colleagues, unfortunately, and they did that with dignity and high professionalism while taking care of others in the line of duty. For me personally, it wasn't the first time that I picked up the phone and made phone calls to patients to make sure they're doing well. We do that routinely in all patients that undergo cardiac catheterization. We ask them for the access site. We ask them for symptoms, and we were used to. However, with COVID and canceling most of our clinics, or I should say all our clinics, elective clinics, it became something different. I have had many virtual visits with patients in the past, and I did see that to some degree it's possible to use telemedicine as means of delivering care to our patients. However, in my profession as an interventional cardiologist is a little bit different. Why is different? Because most of my patients complain of chest pain. Most of my patients complain of shortness of breath and angina equivalent symptoms, which means that they would need an urgent EKG. And I did have patients that they called me through family members, and I had to refer them to closest urgent care centers, which we have now around the country, sort of limited ER, and or like they work like clinics, but mostly for urgent stuff, and where they get the EKGs and whatever is needed. EKGs, it's a problem. You cannot get them remotely. Yes, there are different devices that you can get up to three lead EKGs. However, patients don't have that available at home. Or doing a stress test, doing a cardiac catheterization, and other necessary diagnostic tests and treatment options are very limited in cardiology. However, I want to tell you, I got this invitation a little bit late. I was on vacation, and when I came, didn't have enough time to prepare. But hopefully in the future, I'll show you that in cardiology we do have a robot in interventional world, and we use the robot to help us do the interventions. Still, the human presence is necessary, but not at the attending level, not at the specialist level. So a trainee or a scrub tech or a physician assistant, somebody in the room can help, but from outside the room robotically, and we can do also interventions. With telemedicine, we learned another thing during this crisis, that we can collaborate, we can work together. And I had so many phone calls with colleagues back home. I was born in Kosovo, and even though I left a long time ago, I am always there with my heart and soul and I have my friends, and during crisis, we would consult and we would talk about how to manage patients with COVID and heart attacks at the same time. And that brought the medicine, the telemedicine, to another level. We routinely use offsite radiologists to read radiology images, pathology slides. So with that in mind, this is a great opportunity for us to expand in terms of becoming another pair of eyes and ears outside of that spectrum. Not every country has the luxury to train people for years and years. I know in Europe, usually to become a cardiologist, about 4 years of training. In America, it's 6 to 7 and 8 years. So not every country has that possibility. I'm talking about poorer countries, third world countries. So in that, with that in mind, we by using telemedicine, we can always try and get together and be true friends and colleagues and provide the best care for our patients. I see this as an opportunity to modernize the cardiology and to modernize the medicine in general by getting together through this means of technology that we have now. In my experience as a consultant in a startup company with remote monitoring, what we're doing is we're gathering the data from each patient that is monitored, and we monitor big institutions, one of the most prestigious institutions in America. And we have about 50,000 patients now that we monitor. And the physician, when he looks, each patient gets, it's a machine learning also technology, where the machine is going to learn the patterns of doctors reading. So if doctor is reading AFib in a chronic AFib patient, the same pattern, and he keeps ignoring that because he knows the patient is an AFib, next time he's not going to prompt the doctor saying, hey, look at this EKG, look at this rhythm because patient was in AFib. So machine learns by itself through artificial intelligence and makes the doctor's life much easier in terms of as opposed to going and looking at the software and see the patient had an arrhythmia. Machine is going to tell him patient is at usual state of health, so move to the next patient, instead of spending minutes to review the monitoring sequence on a software. The doctor can move to next patient, and that's what's facilitating and making everybody's life much easier. So there's a room for improvement. A lot of patients, they want to see the doctor. They want the doctor to touch them. Elderly patients are having harder time and will continue to have harder time to use the devices. We have to be very mindful of that, and especially the ones that live alone. Here in America, we have a healthcare system that allows for patients that are alone and not able to take care of themselves to have somebody to help them, but they are not allowed to give medication. They're just purely for physical help, to cook, to clean, to shop, and do the small things. And it's called health attendant. So somebody who attends and helps them with needs. So it's a work in progress, I think. There are areas in medicine that we can collaborate and make this really work, but I think we should always put ourselves in patient's position, and patient wants to doctor to feel that articulation that is hurting, not just to order an MRI or X-ray and send me the pictures, text me the picture, or upload the pictures. So it's a work in progress, and I just want to thank you all for inviting me to participate here. I learned a lot from all of you, and we'll see how technology is going to evolve and what can we do better for each other and our patients.